Thank you so much. I want to thank the organizers for inviting me to this wonderful conference. Next, well, I have to push myself, sorry. I have no disclosures. So today, I'm going to concentrate on two main topics, mast cell and cirrhosis, and I will pull from the AASLD guidelines, as well as a few abstracts from Digestive Disease Week and the liver meeting. So let's start with mast cell, or mast cell D. So everyone here knows that mast cell D is so prevalent in the general population at 30% or more, and in patients who are obese, almost up to 80%. Now, we know that fibrosis is incredibly important for a liver-related mortality. But I think we're now recognizing that baseline fibrosis also predicts all-cause mortality. And so where you see the curve go up is about stage 2 and 3 fibrosis, which is why this has been the target of all these wonderful new therapies that are coming up. So in the United States, resmetirom was approved as the first MASH drug for at-risk MASH. The main thing is AASLD came up with guidelines because based on the studies, the inclusion criteria was biopsy-based. And what AASLD wanted to do was recognize that this is really not practical. And so looking at the data, they came up with recommendations for starting and stopping rules based on non-invasive, such as transient elastography, in the hopes that this would help insurance companies cover this medication. Now, I think everybody knows that the most exciting thing that came up in the TLM for therapies of MASH was the phase 3 trial, the ESSENCE trial for the semaglutide in at-risk MASH. This was a late breaker abstract and was also now published in the New England Journal. And as you know, it was just FDA approved for this indication. So this study, just to refresh everyone, was similar to every other MASH therapeutic trial, which was biopsy-based. So this is a stage 2, 3 fibrosis. Patients can have or not have diabetes. And this was a planned interim 72-week analysis of the first 800 patients. The randomization was 2-to-1 for semaglutide versus placebo. So I want to point out a few things here. So I think the age is pretty similar between placebo and semaglutide, around the 50s. Females were about more than half. And there was a nice distribution. This is a global study, so there was a nice distribution of races. Interestingly, you should note that there were Hispanics, about 17 to 19% in the two groups. This was a mostly obese population with an average BMI of 34, 35. I think what's important to point out is that actually the percentage of lean patients in this cohort, this study, was actually quite low. With diabetes, they were not allowed to be already on GLP-1s, but there was about more than half had diabetes. So they met their primary endpoint, which is why they got approved. You can see that they had resolution of steatohepatitis with no worsening liver fibrosis. A reduction, most importantly, was the reduction in liver fibrosis, which is meeting their primary endpoint. So interestingly, in this presentation, you know that there was also a similar reduction in non-invasive markers, such as the ELF, Enhanced Liver Fibrosis Score, and liver stiffness, as well as, understandably and expected, a weight loss of 10.5% versus 2% in the semaglutide versus placebo. There was similar adverse events with actually not too many people withdrawing or changing dose. Of course, as we know, semaglutide does cause GI side effects, but was not enough to cause withdrawal from the medication. So in summary, at the planned 72-week interim analysis, the GLP-1 semaglutide met its primary histological endpoint and showed an improved liver fibrosis, both biopsy and non-invasively. There was a similar effect in both diabetic and non-diabetic patients. This did not address cirrhosis patients. I think that's very important to note since many of our patients are cirrhotic by the time they see us. And this study really didn't address the lean MASH patients. So what's new in cirrhosis? I want to point out that the AASLD came up with a practice guidance on risk stratification and management of portal hypertension and varices in cirrhosis and brought up some new, more acceptable terms. As you know, cirrhosis is diagnosed histologically, and so there was the acknowledgement of compensated advanced chronic liver disease, which is similar to compensated cirrhosis. But more importantly, there was this recognition of clinically significant portal hypertension, which is a hepatic vein pressure gradient of greater than 10. As you know, that increases your risk of overt hepatic decompensation, which would increase your risk of death. And more important, with the PREDICE study, it's important to recognize that our whole thought about beta blockers has changed since in that study, beta blockers not only prevented the first bleed, but also there was a decrease in hepatic decompensation, particularly ascites. So the idea that beta blockers, non-specific beta blockers, could stall the progression of liver disease is incredibly important. So given that, the AASLD guidance recommended using what Bravino 6 recommended, which is the rule of 5, using a combination of liver stiffness and platelets rather than hepatic vein pressure gradient to try to define clinically significant portal hypertension. And the reason for this is that most of us do not have access to good hepatic vein pressure gradient measurements throughout the world. Caution should be used, though, even though this is an easy thing to remember, that this is actually not as accurate in MASL patients with high ALT or PSC with a dominant stricture. And the favored medication now is carvedilol at 12.5 milligrams daily. It can be given once a day versus BID. Is favored for clinically significant portal hypertension. So empiric treatment is being recommended, and the consideration would be similar to the Bravino 6 criteria, which is consider not doing endoscopy if the platelet is greater than 150 and liver spleen stiffness is less than 20, and actually do not need to repeatedly do EGDs because, as you know, that's a very qualitative study. So unless the patient bleeds, we can actually decrease a fair amount of endoscopies for surveillance. So the practical approach, if there's presence of clinically significant portal hypertension, consider a beta blocker for primary prophylaxis to prevent the first bleed and decrease risk of hepatic decompensation and death. Carvedilol is a treatment of choice. And so if the patient's already on beta blockers, consider converting them. And once you're on beta blockers, no further need for variceal screening is indicated unless they bleed or have other indications such as intolerance. So one of the studies that kind of points us to all of this use of transient elastography is liver stiffness measurements to predict HCC risk. This study was done in the VA and started with 30,000 participants to try to find patients with MASLD and had a liver stiffness. And what you can see here is that essentially liver stiffness, as you increase the number, the liver stiffness, the occurrence of liver cancer per 100 person years increases. And if you use the 0.4 cutoff for cost effectiveness, this points to that you could use perhaps 16.2 as a cutoff to see when HCC surveillance may be cost effective. So in this study, liver stiffness was associated with HCC risk in MASL patients, and every 5 kilopascal increase resulted in a 19% increase in HCC risk. And using that cutoff of 0.4% per year, HCC surveillance was thought to be cost effective. You can also stratify patients based on whether they have diabetes or not. This was all recommendations for male, because in the veteran, that was usually the significant number of patients were male. So this was another very intriguing study that was presented by Dr. Bajaj, which is involving secondary SBP prophylaxis in patients with new SBP. And this, again, was in a retrospective study on veterans. So the background is that you know that the present guidance suggests that after an episode of SBP, secondary prophylaxis is recommended with fluoroquinolones or with Bactrim based on this old data. In this study, this group has already shown that they're actually in the VA cohort as well as a non-VA cohort, the TriNext, that secondary prophylaxis actually increases SBP recurrence risk. And so this study was actually looking at the occurrence of non-SBP infections on people who were given prophylaxis. What they saw was they started with 4,673 veterans. Again, this is a retrospective study. They looked at these patients and found that about 50% of them, only about 50% actually got secondary prophylaxis after they left after they got their first episode of SBP. And most of them got the fluoroquinolones, 15% got the Bactrim. So as I mentioned you before, the recurrence rate actually is higher in people who got secondary prophylaxis versus those who did not. But more interesting, in red, you can see that the percentage of non-SBP infection was also statistically increased. Okay. So given that this is a retrospective study, you can imagine that those people who got prophylaxis after secondary prophylaxis actually was completely different from those who didn't get it. So in general, those who got secondary prophylaxis were sicker. They had higher MELDs, and they were more likely to use proton pump inhibitors and many other features. And so one of the things they had to do was a multivariate analysis to see if this was really an effect of the difference in the two populations. Oops, sorry, I gotta go back. Whoops, okay. But what they found was indeed even after adjustment on a multivariate analysis, you can see that there was an increase in non-SBP infections, as well as their previous study that showed that actually given secondary prophylaxis increases the risk of SBP recurrence. So this is very concerning because that is not what our guidance is right now, and the data supports that we should reevaluate the risk-benefit ratio of secondary SBP prophylaxis. So key takeaways. We all know mast cell is highly prevalent worldwide. Liver fibrosis predicts clinical outcome, both hepatic and extrahepatic, and used to stratify at-risk MASH. Diet and exercise, of course, are the mainstay of at-risk MASH, but there's now a new plethora of medications that will be available, particularly the GLP-1s here, which may reduce fibrosis. All the clinical trials utilize biopsies as the gold standard, but this is really not very practical in clinical practice. And for the newly in the US, FDA-approved resmetirom, AASLD guidance suggests that there are potential cutoffs for liver stiffness. And we anticipate that we will be releasing soon for the newly approved FDA GLP-1A semaglutide. We will have guidance in regards to cutoffs as well. The key takeaways for the care of patients with cirrhosis, utilization of non-invasive markers can identify the onset of compensated advanced liver disease and clinically significant portal hypertension. Carvedilol at low doses should be considered for cirrhosis patients with clinically significant portal hypertension. Liver stiffness measurements has the potential to predict HCC risk. Secondary prophylaxis for SVP may have unintended consequences of increasing infection and really needs to be reassessed. So I want to acknowledge that many of these slides came from the authors, Dr. Kaplan and Lena Allen, Monica Sarkar, and Nihar Parikh, who did the AASLD guidelines, the debriefs at the AASLD. So thank you very much for your attention.